You're listening to Medscape's In Discussion series on colorectal cancer, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Benjamin Schlechter. Dr. Schlechter is an academic medical oncologist at Dana-Farber Cancer Institute and instructor in medicine at Harvard Medical School. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Benjamin Schlechter, and welcome to Medscape's In Discussion series on colorectal cancer. Today we'll be discussing the approach to stage 2 and stage 3 rectal cancer with our guest, Dr. Harvey Mamon. Dr. Mamon is chief of the Division of Gastrointestinal Radiation Oncology at Dana-Farber Cancer Institute and an associate professor of radiation oncology at Harvard Medical School. Dr. Mamon, thank you for joining us. You are a nationally recognized voice in the treatment of GI malignancies, and in particular rectal cancer. I personally found your perspective on this disease to be very balanced and thoughtful, and also really helpful in navigating the complexities of rectal cancer management. Before we talk about the data today, first, why don't you tell us your pathway to GI oncology and how you landed here in this field?
I have a background in molecular biology, specifically cancer research and signal transduction. So I was drawn to oncology as a medical student. Through a series of coincidences, I ended up in radiation oncology. And when I finished residency, there was a need in GI, but it was also, I found that the collaborative nature of GI radiation oncology with so much input from medical oncology and colorectal and surgical oncology, not to mention pathology and radiology. I really enjoyed that collaboration and the feeling that patients were getting the input from a whole team of people who were really committed to finding a customized, just right treatment for each patient.
Yeah, that does seem to be a theme among GI oncologists. Not many people go into it thinking they'll be a GI oncologist, but most of us seem to end there. Let's talk about Prospect. This is a really, really important trial that was presented at ASCO this year in the plenary session by Dr. Deborah Schrag, and it was also a synchronous publication in the New England Journal of Medicine. And I was hoping you could give us a little background on how this trial was developed and what was found.
Sure. So, all of us in the oncology community are always striving to maximize both the efficacy and the tolerability of treatments. Surgery, radiation, and chemotherapy are all effective therapies, but they all have associated toxicities. So to the extent that any of these can be minimized without compromising efficacy is a worthwhile goal. The Prospect trial is really based on a small single-arm phase 2 study done at Memorial Sloan Kettering. It was Dr. Schrag, who was the Prospect PI, as the first author of that study. It was done back in 2007 to 2008 with just 32 patients who had stage 2 to 3 rectal cancer. They received 6 cycles of FOLFOX. At that time, they actually included bevacizumab during the first 4 cycles, although that part wasn't carried forward to Prospect. Of the 32 patients, 2 stopped chemotherapy because of cardiac complications and went on to chemoradiation. But the other 30 all had tumor regression, and 8 of them, or 25%, had a pathologic complete response. The 4-year disease-free survival was 84%, and there were no local recurrences. So that was quite impressive results for really one of the first trials to take radiation out of the picture. The discussions with CTEP, as I remember at the time, were very interesting because, they were more ambitious than we were in some ways. We thought after just one single institution, 30-patient trial, a very novel approach. The next step would be a multi-institutional cooperative group, a phase 2 trial to confirm the findings. But we were encouraged to go right ahead to a 1,000-patient phase 3 trial to really ask this question and get an answer. And so it ended up being designed as a seamless phase 2, phase 3 trial where there was a phase 2 component to confirm that we wouldn't be hurting patients with this approach, but it was built in to carry in directly into a phase 3 with several data monitoring points along the way to assure safety.
Excellent. And can you comment on sort of the patient factors here? what's the morbidity? What are the injuries that we're avoiding with radiation? What are we gaining versus losing in this population?
Well, that's a super interesting question. And one of the themes that may come out today is the importance of doing trials and not assuming that we know the answers to these questions. If you read the actual protocol document, which is accessible with the New England Journal publication, the statistics section says that if the oncologic outcomes are equivalent, we'll no longer need radiation, because the assumption was the toxicities of radiation, such as sexual function, infertility in young patients, bowel function, would be so morbid that, of course, we would want to eliminate the radiation. In fact, the results were more complicated than that. Probably the Medscape listeners don't need to know this, but in the popular press, this has often been presented as chemotherapy alone versus chemotherapy plus radiation, making it sound like the chemotherapy is the same in both arms and adding radiation can only add toxicity. But in fact, as I think all of our listeners know, when you do chemoradiation, it's with low-dose 5-FU or capecitabine, but the chemotherapy alone is FOLFOX, which it has its own set of toxicities. So actually, I think the finding was surprising to some people, was that during neoadjuvant therapy, grade 3 toxicities were significantly higher with chemotherapy than with chemoradiation, at 41% versus 28%. So you really can't say that omitting radiation decreases toxicity. You could actually say it increases toxicity, but I think a more accurate description is that it changes the type of toxicity. And there's an accompanying JCO paper that came out the same day as a New England Journal paper that goes into great detail about patient-reported outcomes and toxicities. And so I think the real take-home message from Prospect is that we have a new option on the table, which is neoadjuvant FOLFOX without radiation for selected patients who fit the eligibility criteria, and that patients now can look at the toxicity profiles of these two different oncologically equivalent treatments and decide which makes the most sense for them.
And what's the population we should be taking the Prospect approach in? So is this for all rectal cancer? Who specifically are the patients that we should consider a chemotherapy approach with imaging assessment of response, where if there's under response, we proceed to chemoradiation, if there's good response, we proceed to surgery?
Going through this and analyzing these results and seeing the responses we've gotten and the reviews clarified to me that although we use the term locally recurrent rectal cancer frequently, and that usually means the patients for whom we do radiation, which is a T2 node positive or T3 to 4 node negative or node positive, that in fact, locally advanced rectal cancer is a spectrum of diseases. And because we were nervous about omitting radiation, given how many studies there had been done prior to this showing a significant local control benefit to radiation in study after study, we were very cautious, and we limited the trial to really the favorable subset of locally advanced rectal cancer. And what I mean specifically by that is that we know distal rectal cancers have a higher recurrence rate in most studies, not in all studies, than proximal rectal cancers. So one of the criteria was that a surgeon had to see the patient before going on trial and say that they would be candidates for sphincter-sparing surgery if the tumor was so distal that an APR was anticipated. They were not eligible for the trial. Similarly, we defined a nodal risk of 4 or more lymph nodes over 1 centimeter in short axis. T4 tumors were excluded. Any tumors or lymph nodes within 3 millimeters of the mesorectal fascia because of the risk of a positive radial margin without downstaging were omitted. So that really leaves us with a more favorable subgroup of patients, which may be why the results were so much better than we anticipated and why it took a long time to get an answer from this study. There were really fewer events in both arms than anticipated from historical controls, with only a 2% local recurrence rate in both arms, which is really much lower than any other publication of rectal cancer.
That's helpful. So this really is a study of the mid and high rectal cancers, the less locally advanced without threatened CRMs, as opposed to a basket application to all rectal cancer?
That's right. I mean, 15% were within 5 centimeters of the anal verge, but they would have been at the closer to 5 than 0 because they had to be candidates for sphincter preservation, and 85% were at 5 centimeters and above.
So moving inferiorly, when we think about the lower rectal cancers, that's where the conversation for non-operative management often comes up. And so I want to talk a bit about the OPRA study, also out of Sloan Kettering, led by Dr. Julio Garcia Aguiar. So this was also an important practice-changing TNT study where chemoradiotherapy followed by chemoradiation was the winner compared to chemotherapy followed by chemoradiation insofar as the outcome was non-operative management and sphincter-sparing approaches. How does that fit into your practice and how you think about this disease?
As we discussed earlier, if we can omit one of the 3 modalities, chemotherapy, radiation, or surgery, while preserving efficacy, that will benefit our patients. The prospect approach was to omit radiation, and the OPRA approach was to omit surgery. And surgery probably has the greatest impacts on long-term quality of life. So studies of non-operative management have been going on for decades, pioneered by Dr. Harvey, a very well-known Brazilian colorectal surgeon. OPRA has been the major U.S. study in this field, and its successor, the JANICE trial, is currently accruing patients at a good pace. In addition to including non-operative management among the many options for patients with rectal cancer, I would say that the sequencing question in OPRA has impacted my clinical practice, and again shows the importance of doing clinical trials rather than assuming that we understand more than we do. And what I mean by that is that the first generation of TNT trials, of total neoadjuvant therapy, all started with chemotherapy. And the assumption, which is a very reasonable assumption, is that early treatment of potential micrometastatic disease would decrease the risk of distant metastases and improve overall survival. But in fact, this didn't happen. And the oncologic endpoints were the same whether chemotherapy was given before or after chemoradiation. However, what the OPRA trial showed was that giving chemoradiation first did increase downstaging, perhaps just because of a longer interval from radiation to surgery, without compromising any other oncologic endpoints. There's a German trial that asked the same question and had the same results. So I would say the impact on my practice is that the sequencing that was used in OPRA has become my preferred sequencing in most patients, starting with chemoradiation, although there are certainly exceptions, patients with big lymph nodes or high CEA that we're especially worried about systemic disease, that we will still start with systemic chemotherapy.
Yeah, so those patients with those more locally advanced cancers, bulky nodes, really symptomatic tumors, really low tumors, those are ones that I also feel like are often a discussion, and we end up navigating into data out of Europe, where we end up with the Rapido study and PRODIGE 23. And so those are also practice patterns that I think could inform this discussion. Maybe we could talk about PRODIGE 23. That was the clinical trial out of France, led by Dr. Terry Conroy, where FOLFIRINOX was used as a neoadjuvant chemotherapy approach, followed by chemoradiotherapy, and then a hold, total mesorectal excision, either APR or LAR, and then adjuvant FOLFOX. It was 6 months of chemotherapy with the addition of irinotecan, just like in the JANICE trial that you just referenced. We saw follow-up data of PRODIGE 23 at ASCO this year, where there was a persistence of benefit from this sort of intensified chemotherapy approach, but non-operative management wasn't commented on. The other trial that we think about in this setting is Rapido, and this was Dr. Renu Bahadur's study in The Lancet in 2021, where short course radiation was used, followed by 4 months of doublet chemotherapy. So how do you incorporate these regimens into your approach? And what are special considerations in short course versus long course radiation, for example?
Yeah, so happy to talk about both of those. I mean, they do definitely both make their way into my routine practice, and both interesting and important studies. Maybe I'll start with PRODIGE 23, because unlike all of the other TNT studies to date, this one, with the update at this year's ASCO meeting, actually showed a significant survival advantage. up until now, we've seen advantages in other endpoints, but not overall survival. PRODIGE 23, I'd say, was already very much on the map, but now it perhaps needs to be considered even more strongly with the survival advantage. And, even before this happened, it had other favorable outcomes that I know we have colleagues at other institutions that have made it sort of their default treatment for most patients with locally advanced rectal cancer. I think putting it in context with PROSPECT makes it harder to take PRODIGE 23 as the de facto standard of care for everybody. And the reason I say that is we now have evidence of improperly selected patients in the more favorable locally advanced group that just neoadjuvant or induction FOLFOX without radiation, although most patients did get adjuvant FOLFOX as well, you can have outstanding results for the lower risk locally advanced rectal patients, which makes me think that PRODIGE 23 is probably overtreatment for many of those patients, because adding irinotecan, giving everybody long course chemoradiation, doing surgery on everybody, and adding adjuvant FOLFOX is a lot of treatment. And although it's hard to argue with a survival advantage, when you're seeing good results with other approaches as well, it makes me feel that PRODIGE 23 is probably best for the more advanced patients, although the protocol wasn't designed that way. The protocol was really designed as kind of a vanilla locally advanced rectal cancer population.
Yeah, and the control arm of PRODIGE 23, I think, is important to look at, because the completion of adjuvant chemotherapy, the control being chemoradiation, an 8-week hold, APR, LAR, and then adjuvant FOLFOX, it's notable that many patients receive no adjuvant therapy even in the control arm. So in many ways, you're comparing 3 months of FOLFIRINOX to a whole lot of nothing. And that may inform the data when the control arm is a little bit different than, say, the PROSPECT as the cross-trial comparisons, that thing that we should never do, but that thing that we often do.
Right. Fair enough. Right. I think that the take-home lesson isn't going to be that we now know how to treat rectal cancer. I think that the take-home lesson is going to be we now have a lot of good options for treating rectal cancer, and the task that lies ahead of us is deciding or being able to determine which of these many good options is most appropriate for any individual patient.
And when do you reach for short course? That's, I think, the big question.
Right. So that's the next one. So, short course radiation has significant advantages and convenience, helping with financial toxicity. There's a related concept called time toxicity, which is just giving up work and travel and just spending another 4 weeks of your life coming in every day for radiation. And there have been many, many studies comparing short course radiation with long course chemoradiation. And pretty consistently, they show very similar outcomes, both in terms of efficacy and toxicity, which is why the updated Rapido results, which were published this year in the Annals of Surgery, are attracting a lot of attention. So on one hand, they continue to show that short course radiation followed by FOLFOX, when compared to what had been the standard, which is neoadjuvant chemoradiation, surgery, and adjuvant chemotherapy, still has improvements in disease-related treatment failure, which is an endpoint they sort of tailor-made for this trial, and distant metastases, but this did not translate into an improvement in overall survival, which was really identical in both arms. However, with longer follow-up in the most recent publication, the experimental treatment arm with short course radiation did have an increase in local regional recurrence at 10% versus 6% in the standard arm, and that was a statistically significant difference. I think it does need to be kept in mind that Rapido, unlike PRODIGE 23, was designed for the most locally advanced rectal cancers. So in a way, it's almost the opposite of the PROSPECT population. Specifically, these were T4 cancers, enlarged lateral pelvic lymph nodes, extramural vascular invasion, involvement of the mesorectal fascia. These are all patients with high risk of local recurrence. And so it may be that in this population, short course radiation may be a problem in terms of local recurrence, and that in a lower risk population, that wouldn't be the case. But that's speculation because, like you say, we want to avoid cross-trial comparison.
And it looked like those lateral nodes and the higher nodal burden were the ones that had the most struggles with short-course radiation, correct?
Correct.
Excellent. So now as we think about this, let's put it all together for this really, really fascinating and challenging conundrum. When you're seeing patients with rectal cancer, how do you break it down? When do you reach for the prospect approach? When are you going to reach for a more PRODIGE approach or an OPRA approach? When would you incorporate short-course radiation in your practice as you see the broad spectrum of rectal cancer, which is really many diseases confined to one diagnosis?
It's almost trite to talk about the importance of patient autonomy and understanding the patient's perspective and the patient's values and what the patient wants. But that has, with all of these choices in rectal cancer, I think that has become front and center of what we need to be doing. Because as far as we know, all of these treatments can be effective. We don't know which patients will have the best outcomes with which of these treatments, but we do know they have different toxicities. And so I think it really behooves us to understand our patients, to communicate very clearly with them what the differences are among these treatments, and to get their input on what makes the most sense for them. So for patients who want to avoid surgery, which is a large number of patients, I think enrolling on Janus is a very good treatment. With the increase in young onset colorectal cancer and having, women of childbearing age who have a relatively favorable tumor, then Prospect is the perfect treatment because you want to avoid radiation and have a chance of maintaining fertility. And so that's a great treatment for that population. For people who travel a long distance and convenience is an issue, short course radiation for Rapido may be best. Although Rapido was designed for very high-risk patients, I might be a little bit more comfortable with using Rapido in slightly lower-risk patients. And conversely, PRODIGE is a very active treatment that improves overall survival. But, my sense, again, even though it was designed for more average-risk patients, it might be more appropriate for the higher-risk patients. But, if a patient has a desire to avoid surgery, if a patient has a desire to avoid radiation, we have many options now that we can tailor the treatment to what the patient's values are.
Excellent. That's super helpful, and it's a complicated field, and it's an exciting time for rectal cancer. It's good to see these readouts that we've been waiting for, really for over a decade across multiple trials. So today we discussed the management of rectal cancer with our guest, Dr. Harvey Mamon, and we reviewed the recently published data on the Prospect trial supporting an adaptive approach to radiation with lower risk stage 2 and stage 3 rectal cancers. This is clearly a practice-changing result where patients who can undergo chemotherapy with integral imaging and have a good response to therapy may be able to avoid radiation with preserved outcomes. We also discussed the non-operative management trial for stage 2 and stage 3 rectal cancer called OPRA out of Sloan Kettering. And that, again, showed us that for lower risk patients, we can avoid surgery in a subset of individuals, although we have to keep in mind that most of those patients do go on to surgery in the long run, but still a subset will avoid it. This is using a radiation-first approach. We also touched on short-course radiation, and while there are some concerns about local recurrence in particular in the most locally advanced disease, it has a convenience factor that's hard to ignore. And finally, on the addition of irinotecan, which has a role both in the PRODIGE 23 study using an intensive approach of FOLFIRINOX chemoradiation resection adjuvant FOLFOX, as well as the emerging data from the Janus trial, taking the OPRA approach of chemoradiotherapy followed by FOLFOX, and seeing if the addition of irinotecan can improve outcomes. But ultimately, as Dr. Mamon said, we need to personalize our approach for each patient based on their values for toxicity, for outcomes, for neuropathy, for fertility, and for overall functioning. So this is Dr. Benjamin Schlechter for In Discussion. Thank you very much.
Thanks for listening to Medscape's In Discussion Colorectal Cancer podcast series with our host, Dr. Benjamin Schlechter. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on colorectal cancer.